and also thanks, David, for the kind introduction. So I've been interested in this area for some time. I guess it began probably about 9 years ago when I was on the international task force that came up with a clinical definition of osteonecrosis of the jaw, and I think that's been my most highly cited paper, so I've had about 1,200 citations from that paper. So what I'm going to do is give you a brief overview of medication-related osteonecrosis of the jaw, as it's called now, and the impact of oral hygiene on its incidence, and we've published a paper last year looking at that, and also some preliminary data about whether or not teriparatide, which is an anabolic bone-forming drug, might be a useful treatment for this condition, particularly in patients with cancer. And I'm just going to tell you about a randomized controlled trial of teriparatide that we've been involved here with the dental services and Mina Borromeo in particular, who you probably know. So I really probably don't need to tell you that medication-related ONJ is an area of exposed bone in the maxillofacial region that's been persistent for more than 8 weeks. It can occur in the maxilla or the mandible. It's more common in the mandible than the maxilla. And it's associated with exposure to medications. And these include anti-resorptive drugs we use to treat osteoporosis or patients with cancer to prevent skeletal-related events. And they are the bisphosphonates, oral and intravenous bisphosphonates. So the common ones we have in Australia are risedronate, alendronate, and zoledronic acid. And denosumab, which is a monoclonal antibody against a very potent stimulator of osteoclasts called rank ligand. And also it's been identified with anti-cancer drugs. So more recently, there are a whole list of anti-cancer drugs that can be associated with this condition. It's important to differentiate it from osteoradionecrosis, which is present if radiotherapy's also been given. So what is the challenge? Well, there's significant morbidity and a reduction in quality of life associated with this condition. And its management can be very challenging, and it can persist despite antibiotic therapy, both locally and systemic. And this is particularly true in patients with cancer who've been on higher doses of intravenous zoledronic acid or denosumab. So we have to really consider the risk benefits of anti-resorptive agents. And usually in patients with osteoporosis, we only treat patients at high risk with these drugs. And in cancer cases, it's often part of a protocol where people are treated with monthly intravenous or subcutaneous zoledronic acid or subcutaneous denosumab. So they get much higher doses cumulatively. But prevention is paramount. And we need a treatment that can stimulate bone repair because there's a bony defect that's present in these cases. So there have been position papers that have been published on this. This might be one that you're familiar with, and about medication-related osteonecrosis. And this was an update in 2014. And what it did was to confirm the case definition and also provide risk estimates for the problem and prevention strategies and management based on disease stage. So if we think about the risk of this condition amongst cancer patients, it can be quite high. So if you're enrolled in a trial in the placebo group, there's about a risk up to 2 cases per 10,000. But zoledronic acid is 50 to 100 times higher and can be as high as 2% of study populations who may develop osteonecrosis of the jaw. And the head-to-head studies with denosumab have shown that the risk of it with denosumab is really about the same. So again, nearly as high as 2% of people, or 1 in 50 patients on these high doses of drugs for cancer. Now, we have to contrast this with the risk of ONJ amongst patients with osteoporosis. And in these people, they get much lower doses of a bisphosphonate, both cumulatively or denosumab. So if we think about patients receiving denosumab, for instance, for cancer, they get 120 milligrams every month. And if you have osteoporosis, you get 60 milligrams twice a year, so 120 milligrams a year. So the dose in cancer is 12 times higher of these medications, so it's a much higher dose. So with the oral bisphosphonates, the risk is really low. It's as low as about 1 in 10,000 to 1 in 1,000 is probably the highest risk. And there tends to be a higher prevalence with more than 4 years of oral bisphosphonate exposure. Now, in the studies with zoledronic acid or denosumab, again, the risk is quite low. So again, it's 0.01 to 0.04%. And it's about double the risk in the placebo group and 100 times smaller than in the setting for cancer. So it's really important to differentiate the indication for these anti-resorptive drugs in defining the risk of this condition for the patient. Now, there was an ABC 730 report that came out probably about 6 years ago now, and that didn't differentiate the risk between osteoporosis patients and cancer patients. And it showed the terrible pictures you'll probably see later of osteonecrosis. After that TV program, 23% of Australians who'd been taking a bisphosphonate to treat their osteoporosis stopped treatment. And they didn't transfer their treatment to any other treatment. They just stopped their treatment because they thought that was associated with their osteoporosis treatment, which the message was completely wrong. So we went on to the same 730 report 1 week later, but that trend was never reversed. So those patients stayed off treatment. And what that means is there would have been a number of hip fractures and deaths that resulted from those patients coming off their treatment. And that was a paper in the MJA, the prediction of the number of deaths and hip fractures that were caused by that 23% of people stopping their bisphosphonate. So obviously the media can have a powerful effect. And once it's out in the media, as you know, with the FBI, it's very hard to reverse. So when we think about staging and treatment strategies, we can do it at risk category where there's no necrotic bone in patients who've been treated with oral or intravenous bisphosphonates. So obviously patient education might still be important. Stage 0 is when there's no clinical evidence of necrotic bone, but there may be some non-specific findings. And again, there may be pain, so it's really focusing on pain management and antibiotics at this stage. But stage 1 is where there's exposed a necrotic bone or a fistula that probes to bone in patients who are asymptomatic and don't have active infection. So these patients are treated with local antibacterial mouth rinses and a review of the indication for continuing with bisphosphonate therapy. And obviously most of us would stop the bisphosphonate therapy at that stage. Now stage 2 is worse when there's exposed a necrotic bone or fistulae that probe to bone associated with infection, and there's pain and erythema in the region of the exposed bone with or without a pus. So again, these people need a higher degree of treatment with oral antibiotics as well as oral antibacterial mouth rinse and pain control. And often debridement is recommended to relieve soft tissue irritation and infection. Now stage 3 is when there's exposed a necrotic bone or a fistula that probes to bone in patients with pain, infection, and exposed a necrotic bone extending beyond the region of alveolar bone, so the inferior border and ramus in the mandible, the maxillary sinus and zygoma in the maxilla, and it could result in a pathological fracture, an extra oral fistula, communication with the mouth or the nose, or osteolysis extending to the inferior border of the mandible or sinus floor. So obviously this is a very serious condition if this happens. And again, antibiotics are indicated, but also probably more extensive surgical debridement is required. So the risk of this condition has been looked at in the FDA's adverse event reporting system, and this is a large, huge database of adverse events associated with various drugs. And what we see here is that the risk is very high for intravenous bisphosphonates, permethrinate and zoledronic acid, which are predominantly used in patients with cancer, and less for alendronate and risedronate and abandronate, which are used to treat osteoporosis, and also lower for denosumab. And these are the drugs I was talking about that are anti-cancer drugs that are associated with this condition, osteonecrosis. And again, you can get osteonecrosis with these drugs, but the risk is generally lower than with the anti-resorptives. And these are new monoclonal antibody drugs that are used to treat cancer. So there were 17,119 reported cases of ONJ, and the risk was significantly higher in the cancer patients compared with those treated for osteoporosis. And the odds ratio in cancer patients was 125 times relative risk for zoledronic acid and about 5 times for denosumab. And with osteoporosis, the risk was only very, very marginally increased, 1.1 for zoledronic acid, and for some reason it was actually lower for denosumab treatment. So there's limited evidence for risk in the setting of treatment for osteoporosis, and really we should be concentrating on patients with cancer. Now, I think we've been studying the impact of oral hygiene on the incidence of MRONJ, and this was a paper that one of our PhD students, Claudine Sau, published, looking at the role of oral health as a risk factor for ONJ. And she found a strong association between periodontal disease and ONJ, and clinical markers were more commonly present and more severe, and there were higher antibodies, particularly against one bacteria, Porphyromonas gingivalis, and there were also high inflammatory markers in the gingival fluid in the patients that had ONJ, so a higher degree of inflammation. And it's more likely to require extractions or dentures if there's periodontal disease present. There's more likely to be direct bacterial involvement, and the inflammation resulting from this can reduce the healing. So subsequently, I guess, during that time, there were these recommendations for prevention of ONJ in patients with myeloma. And these were published in the Internal Medicine Journal in 2009, and they were instituted about that time at the Peter MacCallum Cancer Centre. So we thought it was a good opportunity to look at the risk of getting ONJ before and after these guidelines were introduced. And you can see that they were introduced in about 2009, and you can see the dramatic falling off of cases. So really this is just to emphasise the importance of good dental hygiene. And at this stage, the reason we wrote this paper is that we're trying to recruit for our randomised control trial of teriparatide in ONJ. We couldn't get cases, and it just didn't figure because we knew the cases were quite frequent before, and we wanted to find out why. So that was the reason. And this just shows the timing of the dose of the anti-resorptive drug before and after the guidelines were introduced, and that the rate really just tapered off dramatically. So if we look at the cases, there were 29 cases from January 2003 to June 2008, and only 5 in the corresponding time period after the guidelines were reduced. So the relative risk was reduced by this very much. And you can see that denosumab was just starting to appear in the latter cohort. So very effective. A significant fall in ONJ cases since July 2008, and it coincided with a greater emphasis on oral health assessment and surveillance in patients with cancer, and reaffirmed the importance of oral hygiene in prevention. However, established ONJ remained a significant management problem, and this is just a copy of the paper for your information that was published last year in the Journal of Clinical Endocrinology and Metabolism, one of the best endocrinology journals. So we wondered if we could treat this, particularly in patients with cancer, because it doesn't remit spontaneously even with antibiotic therapy. And what we planned was an NHMRC-funded study, a randomised control trial, whether 8 weeks of treatment with subcutaneous teriparatide caused resolution of ONJ both clinically and radiologically. And the secondary objectives were to look at quality of life as well as bone formation markers, which often respond to teriparatide. And also we wanted to look at a new marker of osteoblast activity in PET scanning. So it was a prospective randomised double-blinded placebo-controlled randomised control trial of teriparatide in the conventional dose used to treat osteoporosis of 20 micrograms a day, calcium, vitamin D versus placebo. And we had placebo pens supplied by Eli Lilly for the injection, so none of us knew who was getting the teriparatide versus placebo. And all patients got calcium and vitamin D. And we wanted to have 34 patients to each treatment arm. And we extensively used the oral and maxillofacial surgeons in Melbourne and special needs dentistry to recruit patients. And this is just the intervention, and then we follow them up until 12 months after the end of the study. And these are the things that we measured. So obviously dental examination was really critical for clinical staging, and then cone beam CT was done at baseline 4 and 8 weeks, and then at the end of the study to look at the volume of the ONJ lesions. And we also did fluoro PET scans at baseline and at the end of the intervention to see if that teriparatide altered the appearance on fluoro PET. And we also measured quality of life. So we had 73 patients with ONJ referred. A lot were from the dental clinic here. There were also private OMFS clinic patients and some from hematology and oncology, 5 self-referrals from the ads we put out, and a few from other sources. But we're only able to enrol 36 participants for whatever reason, and we've had a total of 26 participants completed the entire study, and 3 participants dropped out. Because of the difficulty recruiting in Melbourne, we had to go all over Australia, and you can see the spread of patients we had in the study. So it's becoming a decreasing problem if you look at good dental hygiene as being important. So we had 17 women, 19 men. The median age was relatively young, 63, ranging in age from 46 to 88, and about 50-50 had ONJ for less than 12 months or more than 12 months. The type of anti-resorptive therapy was for osteoporosis indications in 5 patients, but it was for anti-cancer indications in the vast majority, in 31. And so predominantly myeloma, but also metastatic breast cancer and prostate cancer patients were used. They were generally well tolerated with no adverse events, but the common ones associated with teriparatide are nausea, headache, and anorexia and myalgias. And there weren't any biochemical abnormalities. Now, we're analysing the cone beam CT data at the moment, and what we'll be doing is estimating the volume of the lesion and then seeing if the number of lesions is reduced or some go away completely, or whether the volume is reduced. There are a number of mandibular and maxillary landmarks where we can position each of the ONJ lesions, which you probably know a lot more about than I do. And this just looks at some of the cone beam data. So you can make a cube and make these measurements very precisely of the volume of the lesions that are present. So that'll be very interesting to see. The other exploratory part of the study was the 18 fluoro PET imaging. And this is important because fluoride binds avidly to the hydroxyapatite crystals of calcium and phosphate, and it's a reflection of how active the osteoblasts are. And we want to use this as a possible diagnostic investigation to confirm the diagnosis and to exclude differentials such as osteomyelitis or metastases, and maybe look at the pathophysiology and whether it responds to treatment with teriparatide. So that's a novel part of the study. And we had 30 participants who underwent baseline PET imaging, and 39 O&J lesions were identified, with 8 patients having multiple lesions. So this is not uncommon to have more than one lesion, and the severity ranged from stage 0 to stage 3. And the vast majority of lesions were positively identified. The 4 lesions that weren't were stage 0 or participants with multiple lesions where we didn't pick them all up. So there are 3 characteristic patterns of uptake. One is a rim of intense osteoblast activity around an area of photopenia in 16 lesions and was most commonly observed. And this comprised 60% of stage 2 and 3 lesions, and it's not described with metastases. The other pattern was focal intense uptake and diffuse uptake. So these are just some of the examples of the fluoro PET scans and the uptake that you can see here and here and here. So it's quite dramatic, the images you get with this of the O&J lesions. And this is just another image of some of the different types of lesions. So with that, we don't know what the results are and whether it worked, but there are case reports showing resolution of O&J with teriparatide. So we're just in the process of analysing the data. So I'd like to thank my collaborators, Mina Borromeo and John Seymour at Victorian Comprehensive Cancer Centre now, and most importantly, Ewan Sim, a PhD student who's been working on this, as well as Simon Harrison from Peter McCallum, and Michael Hoffman, who's been involved with the fluoro PET scans, and Claudine, who assessed the patients clinically, former PhD student, and Rita Hardiman, who's doing the hard work of analysing the volumes of the cone beam CTs. So thanks for listening to me, and obviously I'm very interested to see the cases you've got, and we can discuss those.